WCCSradio.com today.
12 minutes after 8 o'clock, it is the voice of Indiana County, WCCS, AM 1160, 101.1 FM, and good morning to you. We are beginning today a series of programs with Dr. Dan Clark and the folks from the Indiana Regional Medical Center. This is National Breast Cancer Awareness Month. He, of course, is heavily involved in that battle, and it is a battle. Good morning.
Good morning. Good to be back.
Well, it's good to have you back in the studio with us here today. Not only is this National Breast Cancer Awareness Month, this is also National Hereditary Breast and Ovarian Cancer Week.
Correct.
This very week.
Yes, that's correct.
Let's break it down a little bit. Is breast cancer a hereditary disease, or can it be?
It can be. And it's a small percentage of the breast cancers we see, but it's a huge difference in treatment and how you evaluate the families if you do carry the risk.
That being the case, it seems like there ought to be some sort of genetic indicator, correct?
Right. Yeah, and the biggest indicator is your family history. And if you have family members who have had breast cancer at a young age, or if you've had family members who have had, more than one family member with breast cancer at any age, or other cancers associated with it, such as ovarian, men with young men with prostate cancer under the age of 55, things like that increase your risk of having the genetics for breast cancer.
All right, so there must be a scientific way to approach it then and look for it. I'm assuming we're trying to identify certain genes?
Right. There's two main genes that we look at right now, the BRCA1 and BRCA2 genes. Mm-hmm. And I always tell families that, this is just the tip of the iceberg with genetics. We're really in our infancy of understanding genetics, but the BRCA genes, as we call them, have been very well established. And if you carry the BRCA1 gene, you have between a 65 to 75% chance of getting breast cancer in your lifetime. Mm-hmm. And the BRCA2 carries around a 45 to 50% chance. And these estimates vary depending on which articles you read. But the main thing is that it's a high risk, and it's either breast. And so there's a lot of things we do to step in to kind of prevent that.
Okay. So that being the case, then the testing obviously has to be done as early as possible in someone's life if they have those early indicators.
Yeah, we recommend coming in, 10 years younger than the youngest person who had cancer in your family, because then it gives us time. It gives you time to make decisions. Sometimes we do the testing, or most of the time, I should say, we end up doing the testing after the diagnosis. Because somebody comes in with breast cancer and we interview them and find out they meet the criteria that they might be at risk for carrying the breast cancer gene. So we'll do the testing at that point.
Seems like we ought to be able to jump to the other side of that line, though, doesn't it?
That's the hope, getting the news out there about the risk factors. And, if you have somebody who has a known history of being BRCA positive, as we say, having the gene, you should be tested ahead of time. There's only a 50-50 chance that you have it. We used to think it was a sex-linked gene that was inherited, so we only took mother's history. We now know that was not correct. It's an autosomal dominant gene that's inherited from either parent.
Oh, okay.
But if you have it, there's only a 50% chance that your offspring will have it, or your sister would have it, or your brother. Because actually, men need to be tested as well, because it carries an increased risk for male prostate cancer at a young age, under the age of 55. Mm-hmm. It also increases their risk of male breast cancer as well.
So the testing, I assume, then, is done locally, right here in Indiana?
It is now. That's one of the things I brought to Indiana County. I've been doing genetic testing and counseling. It's not just a test. That's we talk genetic testing, but it really should be genetic counseling.
Okay.
And I've been doing genetic testing along with the counseling for 8 years now. And where I was before didn't have anybody doing genetic testing or counseling in the county where I was. And I had the largest breast cancer practice in the region at the time. Mm-hmm. So I went and learned about it and read up about it, and I maintained my what we call CME, my Certified Medical Education requirements every year to stay up on track with it. So I do the counseling and the testing in my office, and that's something new to Indiana.
Describe that test for me. What happens?
Well, there's two ways of doing it. The most accurate way of doing it is a blood test, and that's the way we used to have to do it. But nowadays, we can actually get it from what's called a buccal smear. We can get it from the cells lining the insides of your cheek, inside your mouth. So I always say it's a gargle and spit. And we have kits that you can just actually, we fill up your saliva in a little tube in the office, and then we send it off to the company. And 90% of the time, they have enough from that they can do the testing.
It seems like there ought to be a lineup at your door right now after having said that, and the testing available now here in Indiana.
Right.
People, I mean, everybody knows within their family whether they have that sort of a history, and that should, I mean, why not? That's something they need to do.
Well, the big why not is it comes with a lot of baggage behind it, and if you have the testing and you test positive, you need to be willing to talk about the ramifications of that testing. Because it doesn't only lead to increased risk of breast cancer, but it also increases your risk of ovarian cancer as well. And so it depends on which gene is positive, what your risks are. So it has a lot of things that go along with it. That's why it's not just a test. That's, when I meet somebody and talk to them, counsel them about genetics for breast cancer, it's a long appointment. And I go through a detailed family history, what we call a 3-tier generation history. And so it's real important to get that data before you come in for the appointment. You want to know not only your mother and father, but your great aunts and your great uncles' history. You want to know, your brothers and sisters' history and their offspring's history. So we want to do a detailed family history to see if you are at increased risk and do need the testing done.
We're talking with Dr. Dan Clark this morning at the Indiana Regional Medical Center, Breast Cancer Awareness Month, and this week is, I'll get it straight again, I have to look because I can't. It's National Hereditary Breast and Ovarian Cancer Week. This is a fascinating conversation. I really want to get into this a little bit. A few years ago, several high-profile celebrities were identified as having the gene, and they decided, I'm going to get the mastectomy. I'm just going to eliminate that possibility right now.
Right.
Has that become more common because of that? Is that one of the recommended courses of action?
Yeah, actually, we have a name for that. It's called the Angelina Jolie effect.
Okay.
It actually had a huge impact on our treatment of breast cancer because now we had a lot of women coming in and requesting mastectomies. And if you do not carry the breast cancer gene, the long-term survival between a lumpectomy and a mastectomy is identical. And so there's not a benefit from a cancer standpoint of having mastectomies if you don't have the gene and some other factors. But it's an option, and so I always, when I teach the residents and I talk about breast cancer in talks, there's two sides of treating breast cancer. I can talk about the statistics and what we call the oncologic treatment or the cancer treatment side and, the pros and cons of the treatment. But then there's a huge psychological side to treating breast cancer. And that has to be taken into effect. And that's a very personal thing with each woman that I talk to as to which way they want to go. But most women think that, it's just my breast, I want it off. But if you don't carry the gene, I always make the comparison. If you have a skin cancer, we don't cut your arm off, because we know it doesn't affect survival. If you have colon cancer, we just take that section of your colon out, and it doesn't affect survival. It's the same thing with breast cancer. If you have a small breast cancer, we just take the cancer out. We don't have to take the entire breast, and your survival at 25 to 30 years is identical.
Yeah.
Now, if you have the breast cancer gene, that's a whole different story because you're at a high risk for recurrent breast cancers, including the opposite breast.
And of course, if you have the gene or if you take the further step of having whatever procedure done, you're in for a lifetime of testing, and that's a good thing, isn't it?
That is a good thing. It doesn't stop with the surgery, and different surgeons follow their patients differently. I'm a breast surgeon, and I follow my patients out for a minimum of 5 years after surgery to make sure there's no evidence of recurrence and everything, because the most common recurrence are within the first 2 to 5 years. Unfortunately, with breast cancer, it can occur even later in life. So if my patients are not following regularly with a gynecologist or they're not seeing an oncologist, I will continue to follow them, because they need to be seen by somebody who is involved in breast care for the rest of their life.
We're talking with Dr. Dan Clark this morning here on Indiana in the Morning. It is Breast Cancer Awareness Month, and particularly we're talking today about genetic testing for breast cancer. When you have that test done, you mentioned the counseling, and we've talked a little bit about it. Let's develop that a little bit more. During those counseling sessions, you said they can last a long time. What are some of the areas that are covered?
Well, we talk about, first, the big part of it in the first meeting that I sit down is getting the family history and going through all that. And unfortunately, insurance is a big part of the conversation nowadays, too. The first company that came out and developed the breast cancer testing is called Myriad, and they have the largest catalog of all the results and everything. But you don't just get a BRCA1 and BRCA2 result. Sometimes we'll get these minor variants that we really don't know the significance of. And they're the toughest ones to explain, that we found a variant in your gene, but right now we don't know or think that it leads to anything. But it's going to be put in a computerized catalog, and it'll be tracked over the years. And if there comes up to be a link to anything, we'll let you know. And then later on, I may get notification that they've got enough data that that's not associated with anything. So we have these minor variants, but big family history. And then I have people come back when the test comes back, because I don't just call them on the phone and tell them yes or no. Because if it is positive, then I need to talk to them about the ramifications, what treatments, the options. The most common recommended treatment is a bilateral mastectomy, but there are other options. We can do annual mammograms and MRIs alternating every 6 months, but that's for the rest of your life. And the idea behind that is that to catch it early if it comes up. So there are other treatment options, but then we also need to talk about the risk of ovarian cancer and what kind of interventions can be done to help prevent that risk. And then I need to talk to them about their family members and who's in the family and who should be tested, and also what kind of screening that they should undergo as well.
All right, so let's establish a baseline. When should women, as a rule, have their breast mammograms? And of course, we need to point out that the 3D mammograms are available now at IRMC.
Right.
When should women, as a rule, get it? When should women who have been identified with either of the BRCA genes, how often should they get it?
Well, the recommendation by the NCCN, which is National Cancer Network, which is all the large cancer centers, MD Anderson, Sloan Kettering, Johns Hopkins, excuse me, those major cancer centers all got together and came up with recommendations, because a few years back, the National Advisory Group for the government came out and really shook things up and said, we don't see any benefit for mammograms under the age of 50. You should start mammograms at 50 and only every other year from then on, and you should stop after age 70. Well, unfortunately, that's not correct, and that was based on faulty data. And now the National Cancer Network came out and very strongly said that every woman should start mammograms on a yearly basis beginning at age 40.
Okay.
And that's what the American College of Surgeons would recommend, the American College of Radiology. Some would say we're biased because we're the surgeons and they're the radiologists. Well, the National Cancer Network is, like I say, it's a huge organization with the most prominent cancer centers in the country. And they just came out very firmly and said that last year. Now, if you have a family history of breast cancer, not even the gene, you should get your mammogram 10 years younger than the youngest person with cancer in the family.
Okay.
So if cancer was 42, you should start at 32 with your mammograms. And if somebody in your family is BRCA positive, same thing, 10 years younger at least, but you really should get tested for BRCA evaluation in your mid-20s. And the biggest counseling I have is, when do I tell my kids? If somebody has BRCA positivity, well, when do you talk to your children about it? And that's a tough one because every family is different. But in general, the recommendations are when they're old enough to understand the ramifications and it won't mess up their life. Now, if you have somebody in your family who has breast cancer in the 20s, you're going to need to be talking to them about it in their teens.
Sure.
But unfortunately, that's not that common. I'm not saying it doesn't happen, but it's not that common. But most of the time, it's in the late 30s, early 40s that you see the BRCA positive cancers. So we say, once they're done and they have their life together, they have their schooling done, and the future is kind of in line, and they're mature enough to understand the ramifications, you should sit down and have this talk with them, and then they should be tested so that they can know what to do with it and have time to think about it.
All right, we're just at the end of this segment. People want to get it done now. What do they need to do?
Just call my office. I do the genetic counseling in the office now. There's no need to go anywhere else. Sit down and go over everything with you and decide whether or not you qualify for the testing.
So for that person who right now has gotten out a slip of paper and a pen, what is the telephone number they should be calling?
You hit me a tough one.
Annie, where's Annie? Annie's not here. Annie, come in here.
I never call my own office. That's bad.
Get Annie in here. We'll get the number. Annie's coming in.
I'll have to pull it up on my phone.
Annie,
What's my office phone number?
Grab the phone there, Annie.
The office phone number
Yeah.
is 888-452-4762, and then they can transfer right over.
There you go. Say it
Does that
again.
work?
Say it again.
888-452-IRMC.
Beautiful.
Nice.
Beautiful.
I'm new here. I haven't gotten all those numbers down
There you
yet.
go. I can't remember numbers either unless you put them on the back of a jersey and put them in a program. Dr. Clark, thanks again for coming in. We'll see you again next week.
Sounds good.
It is the voice of Indiana County, WCCS AM 1160, 101.1 FM.